Thanks for the introduction. My name is Stephen Rice. I'm presenting this on behalf of the National Institute of Health Research In Vitro Diagnostics Cooperative. This is the team. I'm a health economist. I'm actually part of the health economics group at Newcastle University, and we collaborate with the Newcastle Cooperative. I was trying to see what projects that the cooperative have ongoing that's related to photonics, this being a photonics roadshow. And the projects that I found that was, as far as I know, definitely photonics related, is a project that we're doing collaborating with the Proteus in Edinburgh. So this technology is use of optical molecular alveoscopy to rule out bacterial pneumonia. Now this is funded by the Wellcome Trust. It's a £2.5 to £3 million research-funded project. The project covers clinical validation of the diagnostic test. Well, what we do in the cooperative, and myself as an economist, is we survey the clinicians to identify adoption issues, identification of the existing treatment management pathway, as Anka mentioned in her presentation early on, understanding the treatment pathway and how your technology fits in that pathway is absolutely essential. And so we will survey the clinicians to understand how they would use the technology in clinical practice and what the effects of using that technology would be. What would it displace? How would healthcare services vary following the use of that technology? And of course, a cost-utility analysis of the new technology versus current practice. In the UK, all major healthcare funding bodies require economic evaluation. Why? Because economic evaluation is all about identifying value for money of the technology for the health system. The Newcastle Cooperative is one of 11 cooperatives in England, centred in 8 cities. These were set up in response to, well, as a recommendation back in 2010, 2011, because of, well, we'll come to that the next slide, but a recommendation to, in order to improve the development and adoption of medical technologies within the UK. And the objectives of the cooperatives are to build expertise and capacity in the NHS, to develop new medical technologies, and provide evidence on commercially supplied medical technologies, including in vitro diagnostics. So, as I briefly mentioned, back in 2011, it was acknowledged that there was a real problem getting medical technologies adopted nationwide in the UK. It can take easily up to 10 years for a new technology to be adopted nationwide. Some reasons for this were poor understanding of the clinical need, lack of appropriate evidence on the effectiveness, accuracy as a diagnostic test, and cost effectiveness of the technology, and a lack of understanding of impact on care pathways and patient outcomes. Another initiative, as a result of back then identifying these problems of adoption, was to create the Small Business Research Initiative. So this is a funding body that provides research funding for small businesses, small and medium-sized enterprises, for new technologies, not just within healthcare, but in many sectors, from 3D cameras of wound care management to virtual motorways for traffic management. I'm currently involved in an SBRI Innovate UK project, which is a £2 million funded grant for a home use test to diagnose exacerbations for patients experiencing COPD. It's a 3-year project. So £2 million, that's a nice bit of money for a small enterprise to do some research. But as a small enterprise, they were probably a little bit too ambitious in what they could achieve within that 3-year period. They wanted to go from finalizing the development of the test to conducting a clinical trial within 3 years. They were warned against it, but they wanted to go ahead. And in the end, they had to ditch the idea of a randomized controlled trial and go for what we were originally suggesting they do, which was clinical validation of the actual test. There are a variety of stages, as I'm sure many of you know, on the development of the technology. You can't just bypass crucial stages. I'm sure most of you know that, but not everybody does. Yet another initiative back in 2010, 2011 was the introduction of new guidance. New programs within NICE. NICE is the National Institute of Health and Care Excellence, known in the popular media as the rationing body for healthcare in the UK. I'll come back to these in a moment, but first of all, the Medical Technologies Guidance was introduced, and later the NICE Diagnostics Guidance was introduced. I'll come back to these later. But first, I need to introduce health economic evaluation, so you have a basic understanding of what I mean by health economic evaluation. It basically concerns the evaluation of the costs and benefits of alternative courses of action, so it's your new technology versus whatever currently is practiced, or there could be competing technologies. And we can conduct health economic evaluation on pretty much anything, any new intervention in healthcare. Now, just so we're clear on a few terms, exactly what we do when we go about a health economic evaluation, we have our technology, our intervention, and we have the cost of that technology to the health system. Let's say we have an intervention that reduces the probability of disease progression, could be medication. With a reduced probability of disease progression, there will be several consequences. And when we conduct a health economic evaluation, we have to identify what these consequences are. So there might be a change in subsequent healthcare costs. People are healthier, we don't need to treat them further down the line in the future. They may live longer, so we have increased life expectancy. They may have increased quality of life, certainly in the short term. Anke was mentioning this morning about quality of life. And that is absolutely essential in an economic evaluation, understand the quality of life change of any new technology. Now, these costs, these consequences, so the first one is a financial, it's a cost outcome, but the other is increased life years and increased quality of life. These are health outcomes. And so they're measured in different ways. So we estimate the total cost of an intervention and its consequences and the benefits. What do we mean by total cost? The total cost is the cost of the intervention and the cost consequences. So it's the two together. That's what we mean by total cost. So when you compare the new technology to current practice, let's say the new technology is more expensive than whatever people currently use. But let's suppose actually the technology results in less healthcare expenditure in the future. Now, if it's cost saving in the future, if the cost savings in the future are greater than the additional cost of the intervention, then what we say is the technology is cost saving. So overall, even though the technology may cost more, actually the technology may be cost saving to the health system in total. And if you can demonstrate that, that's a really good selling point for your product. So we can summarize the results of an economic evaluation. in terms of cost and benefits. So on the vertical axis, we have increasing costs, and on the horizontal axis, we have increasing benefits. If your technology is equal cost compared to current practice, with equal benefits, then we could put a cross in that box. If your technology is of equal benefit, but is actually cost saving in total to the health service, then we could put a cross in that box. That's an excellent selling point. Of course, your technology may cost more. You know, technology has a price to it. There's no guarantee that it will be reduced costs further down the line more than the cost of the technology itself. And so it's more costly, but there are greater benefits, there are greater health benefits. And so we can put a cross in that box. Other names, just to very briefly mention these, other names related to economic evaluation, cost effectiveness analysis. That's where you have outcomes other than cost. You have some health benefits. Cost consequence analysis. Cost utility analysis is where you have, we use quality adjusted life years. So one quality adjusted life year is 1 year in perfect health. If you're dead, 0. So we basically quantify health in terms of 0. Well, actually you can actually have a negative health state. So if you're in a coma, lying in bed, then actually you have a negative health state. And people, of course, do commit suicide. So 1 basically is perfect health for a year, 0 is dead. And we use this in the UK to quite frequently to measure health outcomes for a technology. So I've already mentioned the NICE and what it does. It provides guidance, quality standards in healthcare, in many disease areas, for many different interventions. But you don't need NICE approval to get your medical device adopted in the UK. You do not need it. What you do need is you need your CE mark. You need to conduct post-market surveillance and report adverse incidents. You need to notify the NICE Interventional Procedures Program if device involves a new procedure. But manufacturers are free to market their product, without NICE guidance. But clinicians should inform their hospital, explain to patients the novelty and uncertainties of the new technology, and audit. So coming back to those programs I mentioned in NICE, if you do, so what's the benefit of having a technology go through the included in the guidance? You don't need it. The technology could be in use already before it goes to the NICE program. Of course, the benefit is if it's actually found to be it is of value to the health service and it's included in the guidance, then the technology is much more likely to be adopted nationwide if it's part of the guidance. So the Medical Technologies Evaluation Program is used where the product is cheaper or more beneficial than existing. So it's either the same cost but more beneficial, or it's equally beneficial or cheaper, then the product will go through the Medical Technologies Evaluation Program. If, however, it's more costly, then the technology will go through the diagnostic, well, if it's a diagnostic test. If it's not a diagnostic test, then it won't, of course. Photonics is more than just diagnostics, but if it is a diagnostics and it's more costly, then it goes through the diagnostics assessment program. Lastly, very high impact devices. This may not be relevant to photonics, but very, very high impact devices, such as stents and implants, go through another process altogether. And this is just a summary of what I've just said. Basically, what that's saying is, if it's a diagnostic test and it costs more overall, then it goes through the diagnostic assessment program. So, use of economic evaluation for the small business, or small to medium-sized enterprise. We could probably look at 3 levels. One, the R&D budgets. Secondly, individual NHS institutions such as hospitals, GP practices, and then the health system as a whole, the whole of the NHS. So, at your research and development stages, what product should I invest in? What's the best strategy for bringing the product to market? When it comes to individual service institutions such as a hospital, well, what are they interested in? They're interested in the impact on their budget. So you can do a budget impact analysis on the hospital or the GP practice. And finally, at the national level, the health service level, is it value for money? Is it cost effective? Because even so, so for example, in the middle category, the intervention might be more costly for the institution, but savings may occur elsewhere in the health system. And so the institution that's actually using the product, say the hospital or a laboratory or wherever it may be, they may actually increase their costs, but actually the costs are reduced somewhere else. And the hospital doesn't notice those cost savings, but the health service as a whole experiences those cost savings. The first step in any health economic evaluation is to understand the population that technology is used for. That's easier said than done. There's a sepsis test that the project I'm involved in, and the company finds it very difficult to... Basically, the sepsis test could be used in any number of different populations, in any number of settings. And you have to... The company has to focus itself on where is it going to do its research, on which population is going to do its research, in which setting, and how is it going to market its test, first of all, to which setting, which population. Then you have to understand the existing healthcare pathway. Again, what's the setting for the use of technology? What diagnostic tests are used related to that, your use of your technology, and what are the treatment results? And of course, how is it technology used? How would the care pathway be when you introduce a new technology? So if it's a diagnostic test, which test are you displacing? Are you using your test in conjunction with other tests? How will treatment be influenced with the use of your test? So just as a very, very quick couple of examples of situations how we would go about evaluating the outcomes of a test. If it's a surgical procedure, and we have 2 surgical techniques, then we might evaluate the success and failure, the rate of success of that surgery. But of course there might be complications. And so we work out the rates of complications, and then we evaluate the health outcomes and the resource implications for each of these different categories, whether or not there are complications and whether or not the surgery was success or failure. If, however, it's a diagnostic test, of course, patients may have the condition or they may not have the condition. The result of the test may be that they're test positive or they may test negative. That gives us 4 categories of patients. And we would evaluate the outcomes of every one of those 4 categories. Of course, the outcomes for patients correctly diagnosed need to be better than outcomes for patients incorrectly diagnosed. Otherwise, of course, you haven't got a feasible diagnostic test. It's not going to be cost effective, and that comes back to what Anka was saying this morning. about there needs to be an effective treatment for diagnosis. If there's no effective treatment for that diagnostic following a positive diagnosis, then you're not going to realize any benefits to the patient or to the health system. And all of this whole process of evaluating the outcomes, the long-term outcomes of these tests to the patients, to the health system overall, is very useful in terms of identifying the value, what some people call the value proposition of your technology. Basically, how are you going to market your technology? What's the big selling point? Are they going to lead to big cost savings to the hospital? Because actually you're going to reduce the number of admissions to the ICU, intensive care unit. Can you send people home and not have any admission to hospital whatsoever? Is it just much quicker for? Is it just much quicker for clinicians to use than their existing technology, and that saves up that releases their time that they can go and move on to the next patient, or is it just basically you're going to have better patient outcomes? The patients are going to be healthier. What's the key selling point for your technology for the health system? So my last two slides, research and development questions that economic evaluation can answer. Just to clarify, at the research and development stage, if we develop an economic model, we call this an early economic model because we probably don't have any reliable effectiveness data for the technology or any diagnostic accuracy test. But what we do is we do sensitivity analysis. What we look at threshold analysis. So, for example, we could ask the question, how effective or how accurate does the device need to be for it to be cost effective? What is the maximum price the device could be for it to be demonstrated to be cost effective? Does the product show sufficient economic promise to warrant continued investment? But at the health system level, questions are more like, is a technology at least as effective as current practice? And is it cost saving? And those are the kind of questions that health service institutions and NICE would ask. If a technology is more costly, what is the budget impact? How would it affect your hospital budget? How would it affect the GP budget? These are big concerns for individual service providers. If a technology is more costly, is it value for money? Are the additional health benefits worth more than the additional cost? And I think that is the end of my slides. Yeah. So, thank you.
So, any questions, comments, feedback? Please go ahead.
With due respect, and I may be entirely wrong, but when one thinks of the NHS, one doesn't think, innovation and modernity. One thinks more bureaucracy and conservatism. But so the question is really, to what extent is the NHS really a potential testbed or early adopter of innovative technologies? To an extent it would be interesting in this role. I mean, I'm really interested to see this because it's kind of an anathema, you know what I'm saying? So, do you do that? And if so, have you got some success stories where, young technology has been taken on by the NHS and catapulted from there?
I'm a health economist. I'm not a member of NICE or a funding body, and actually it would probably be useful to have somebody from one of those bodies here to answer that specific question. I can't give you. I don't have enough knowledge about the historical success rate of getting I started off by saying it's poor, the adoption of medical technologies. That was my starting point, and that is why they introduced these medtech and diagnostic cooperatives. That is why they
initiative to correct that.
Yes, to try and improve the situation. To try and these cooperatives exist in order to collaborate with commercial companies, usually small companies, to try and develop and apply for research funds, like from the Wellcome Trust or from the SBRI funding, for example, in order to develop research funding, in order to work out how to develop and adopt their products in the marketplace. So the whole all those things I mentioned about the introduction of the technology evaluation programs at NICE, all of that has been introduced because it's been acknowledged that the UK has not been a great location for testing people's technologies.
I think it really would be a fantastic PR stunt, to be able to say the NHS adopted this very early on, and thanks to that it has saved money, promoted this young British company, blah, blah, blah. Yeah. I mean, I hope it will.
Yes, so do we all.
Thanks.
Any other questions? No. Okay, thank you again.